Colleagues, good afternoon. Welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. So this meeting is being broadcast on the Council's YouTube channel, Hillingdon, London. My name is Keith Spencer and I'm the co-chairman of this committee with my colleague Jane Palmer to my left. So just before we start, if we can just do some housekeeping. Please ensure any mobile phones around you are on silent. Note to chair, make sure you do it first before asking other people to do it. We're not expecting a fire drill, so if the alarm goes off, it is for real, and please follow officers out of the building. Important thing is please keep your microphone muted when you're not speaking. If the red light is on and you're not speaking, it'll cause problems for our broadcast, so thank you. And then unmute to speak. Okay, so we'll now move on to the agenda, and the first one is apologies for absence.
Chairman, we've had apologies from Patricia Wright, we've had apologies from Councillor O'Brien, and we've had apologies from Vanessa Odlin, and Claire Eves is here as her substitute.
Thank you, Nikki, for that. Now, if we move on to agenda item number 2. Tony.
Sorry, I'd also like to apologise because I feel I'm bound to at some point do something wrong, but so I'll get in early. No, I just wanted to, I may be, I'm awaiting something urgent coming in, so I may be interrupted momentarily, so just to let you know if I need to pop out, it will only be for a couple of minutes.
Thank you, Tony. We'll let you off on this one occasion, I think. Any declarations of interest? I'll take that as a no. That's okay. Agenda item number 3, minutes of the meeting held on the 7th of March 2023, doesn't time fly. Does anyone have any comments on the accuracy of the minutes? No. So can I please take those minutes as agreed? Yes. Okay, thank you. And then agenda item number 4, exclusion of the press and public. So what I can do is confirm that items 5 to 10 on the agenda will be considered in public, and items 11 to 12 will be considered in private. Is that acceptable to everyone? Sandra.
Thank you. Could we consider item number 6, the forward BCF plan in part 2 in private, please?
Anyone have any objections to that? No, then that's agreed. We'll take agenda item number 6 in the private part 2 of the meeting. And for any reason, Nikki, I forget, you will remind me. Okay, if we can move on to the integrated care and performance report, and Gary Collier, I do believe you're going to speak to that. Gary, the floor is yours.
Thank you, Chairman. This is the board will notice that this is a shorter report than it usually receives, as we've been a little preoccupied with the preparations for the next iteration of the Better Care Fund plan. What you've got is a report in 2 parts. The first part is actually asking you to consider the end-of-year template that we were required to submit to NHS England a few weeks ago. This is a national template that all Health and Wellbeing Board areas are required to complete. Hopefully colleagues will have had the opportunity to see it, but basically it's just asking for confirmation that we comply with national conditions, seeking our end-of-year position on the national metrics. And on the national metrics, we have, since the template was submitted as a draft, we have now got data on the residential admissions to care homes. So our position at the end of 22-23 was that we were actually green on 3 of the 4 national metrics. The one that we were not on track on was the discharge to usual place of residence, which we missed the target by a small margin. So that's the board will agree that's actually quite good news. And with the board's agreement, I would actually propose to resubmit the template now that in the light of that new information. The board will see from the appendices that the feedback that we were given. The feedback is really in response to preset drop-down menus. So we were asked to provide overall statements as the position, and you will see that our response is positive, which I think is actually accurate. It was accurate at the time. We were also asked to give a couple of successes and identify a couple of the challenges, and see that the challenges that we've incorporated concern the underlying system deficit. But again, within this, we've actually identified how this actually presents an opportunity for us as well. And the second challenge actually concerns the market position. I wondered, Chairman, if just put a pause at that point to see whether there were any comments from colleagues. Actually, Chairman, before we actually do that, I do actually need to apologise to the board, as we've had a slight malfunction with our proofreading process, and if anyone is wondering as to why Appendix 2 is there, that is a very good question. It shouldn't be, and we will ensure that our proofreading process is actually improved next time.
Okay, that's 2 apologies in the space of 10 minutes. That must be a record for the Health and Wellbeing Board. Any questions for Gary?
Ian. It's not a question, but I suppose it would be remiss of me, considering the current climate of pressure on general practice and the public opinion that general practice just isn't actually offering an appropriate service to the public. If the highlights in 11 workstream show that general practice is working harder than ever before, hitting much better targets than ever did before, and I think this needs to be acknowledged at some place in a public forum like this. I would put a caveat on the admission rate for 65 years with severe frailty. Due to budgetary constraints, that service has been curtailed, or will be curtailed for this year, and it'd be interesting to see what the effect of that budgetary curtailment will have on the figures for this year. I think it's a rather sad state of affairs that we have to cut budgets on successful projects because of budgetary issues. Care should always come first.
Thank you, Ian. Any more questions on that? What I would just add is, obviously, against those suite of metrics, Gary, I think being privy to how we benchmark against other North West London boroughs, those metrics benchmark well against the other North West London boroughs on most of those indicators. So just to back up what Ian is saying, but also I think the wider suite, we do well. Not that this is a competition. We're here to serve the people who live in the borough of Hillingdon, but I think it's worthwhile noting that we do perform well against those suite of metrics. Tony.
Just to say the blindingly obvious, I suppose, but for those that haven't been involved in this since the year, whenever it started, Gary, can't quite remember now, seems a long time ago. Yeah, indeed. And actually, just building on Ian's point, that these aren't just dreamt up things. You know, they are things that have been designed in order to support this system in terms of where it's been and where it intends to get to. And so I think your point is one we should note with underlining, because it's not only is it sort of against others, but also therefore kind of in itself, and in terms of the transformative way in which we're trying to sort of move services. And I just fear that in the bigger configurations of things, as they're happening at the moment, that could be lost, or it looks like a list of things that everybody's doing. Well, actually, some of the names may be very similar, but in terms of the impact and how thought out they are for the system, I think we should kind of own that point and note it.
Any other points before I ask Gary to move on with this report? Gary, would you like to continue?
I think Professor Goodman actually touched on part sort of some of the items in the second part of the report, which actually focuses on the achievements and challenges from 2022. And the board will be pleased to know that I'm not going to read them all out. So I think we've actually discussed in previous meetings some of the challenges presented to the Hillingdon system that are set out, and discussed the proposed changes to the operational model, which again are actually reflected within the report, which will influence the work going forward, and which will be reflected within the Better Care Fund plan. Chairman, that's all I really wanted to say on that. And again, if the board has any further comments.
Any further comments, observations, questions for Gary? Nope. Okay. In the light of that, unless you've got anything further to add to that, Gary, the recommendations are that the board approves the content of the 22-23 end of year template with the notes by members in terms of recognising the achievements that have been built and that have been hard earned. Note the comments and the content of the report. Is the committee happy to support that? Yes? Okay. Thank you very much indeed. What I'd like to do now, Sarah, welcome to the meeting. I think this is your first meeting. You're the chief nurse at TSH. You are very welcome. Just for the purpose of the agenda, item 6 has been moved into the private part of the part 2 of the board. So what I'm going to do now is welcome Toby to the meeting. Toby Lambert. Toby, you're very welcome. North West London ICB, who's going to give us a briefing on the health and care strategy for North West London, which the papers are enclosed. Toby, over to you.
So, thank you, Chair, and indeed, so thank you for allowing me to speak today. So, you have in your papers an Annex A and an Annex B on the North West London integrated care strategy. I'm not going to talk you through the papers page by page. I am going to give you some of the the headline messages and refer to a couple of the pages as we go through. So, starting perhaps slightly not traditionally with Annex B, which is the supporting presentation. There is a brief cover note. I think it's about page 83 in your packs. But in essence, so this is a health and care strategy. It is prepared technically by the North West London's Integrated Care Partnership, which is the committee that brings together the local authorities and the NHS across North West London. The local authority membership is generally the chairs of the health and wellbeing boards, including indeed Councillor Palmer for Hillingdon. So that's the body that prepares the strategy. So technically, again, it is a document. Well, technically, it is a document which needs to be shared and owned by the local authorities and the the NHS jointly. So if what I am presenting comes across as being too NHS focused, then we have got it wrong, and I would like you to be telling me that. It is a document for which both the NHS and the local authorities must have regard, using the legal jargon, which in practical terms means do what it says unless you have a good reason why you are not. So you don't have to follow it, but the expectation is that you will. And we have prepared it by building upon the joint strategic needs assessments prepared by each of the local authorities, by building upon the joint health and wellbeing strategies, where some of our local authorities have had those in preparation while we've been preparing the overall North West London strategy, we've worked quite closely with the public health teams to ensure that we are sort of abreast of sort of where the needs assessment and the health and wellbeing strategy is sort of coming to. We tried very consciously not to include anything in it which is either not reflective of what the boroughs want to do or is not a national priority which we are set. So regardless of so whether we might want to or not. So there should not be in it anything which is a sort of North West London different tier to what is either a national imperative or what our sort of local authorities have sort of identified in those sort of JSNAs and joint health and wellbeing strategies. The papers talk you through a bit of some of the challenges which we've identified as sort of facing the population of North West London. So in particular, you will see a chart on slide 80 something. I'll find it in just a moment. 80. It's not handily not numbered, but it would be 88 if it were numbered. Which is on sort of the top left. So disability adjusted life years per 100,000 population. So this is basically a measure of our overall sort of health and well-being. So the population, and across North West London, essentially what you can see is that over quite a number of years, the sort of level of sort of ill health has declined. It's gone sort of roughly flat about sort of 6 to 7 years ago, and then in the sort of the last year or so of this particular series, it's beginning to tick up again. So it suggests that our so the health and well-being of our population is beginning to sort of go into reverse. That time series stops about 3 years ago. Which is handily about when we moved into the middle of sort of COVID pandemic. And we've since that has sort of cost of living crisis, so I suspect it would be heroic to assume that once the data starts coming through for later periods, that we have managed to continue the overall sort of improvement in sort of health and well-being. So that's probably our sort of major challenge. We then sort of go on to talk about some of the challenges sort of facing the health and care system itself. I pulled out 2 or 3 on the following slide, but so we know we have workforce issues. We've got social care workforce here. You could pick virtually any sort of workforce sort of area you wanted. We know we have variation in experience, outcomes, and indeed access. And we know that our sort of access, particularly on sort of the health side, but equally perhaps to a lesser extent on the social care side, is not as sort of where we would sort of want it to be. We then move into some of the sort of reflections coming through from our population, and it has to be said the number one issue which they bring up, despite sort of Ian's noting of the continued hard work in sort of primary care and possibly more than we've ever been doing before, but the number one issue that our population continue to bring up is access, and sort of access to general practice sort of in particular. So we've clearly got further, we need to do in sort of that particular area. We then move through to some sort of shared outcomes sort of across North West London, and we work these up in conjunction with the Directors of Public Health. And what they've done is to take from the work of sort of Professor Marmot on sort of inequalities, the metrics that he suggests we look at, and then we've removed from those any metrics which we felt would not be amenable to working together across North West London. So this is very consciously a strategy that tries to pick out areas where we can go further and faster by working together across North West London. It is not an attempt to try and collate all of the work which individual organisations within North West London are doing. So as a practical example, Marmot has quite a few measures on schools, and it's generally felt that schools, local authority competence, NHS might be able to help a little bit, but it's not very obvious that but we're going to go sort of further and faster on that by sort of working together across sort of North West London. So that hasn't made it through, but there's quite a few bits on sort of the health and sort of public health side that have. That then moves us into 6 sort of priority areas where we do think we should be sort of working together, which is page 93, so in the pack. So first of all, supporting sort of health and well-being. This is where we get into the sort of wider sort of determinants of health, and the particular area of focus for working across North West London is on the sort of employment, partly because we are collectively quite a large employer in sort of North West London across the NHS and local authorities, and hence one might think that we have some levers on that side, but also because we know we can see that one of the major reasons for people in our population who would want to be into work not working is because sort of delays in the health system in particular is inhibiting their ability to access the workforce. The second big area is then on sort of addressing inequalities, a particular focus here on building on sort of the lessons which we've all learnt sort of during COVID, or perhaps sort of COVID sort of reinforced for us, which is first of all that we have quite a substantial hesitancy issue amongst our sort of population, and so how do we engage with the different groups of our population to encourage them to come forward and to engage with sort of health and care services, and then secondly a differentiation of the offer between sort of different groups, because what works for one group won't work for another. So it's been quite systematic about how we engage and how we vary the offer. And the third, so improving access, so a large focus in here particularly on so urgent and emergency care, so we're streamlining those and then sort of rationalising and supporting our sort of integrated neighbourhood teams, which is sort of based around sort of general practice, but sort of putting more sort of resource sort of into those should improve sort of the access there, and it should also address some of the bouncing around we currently get so in the system. So you don't quite meet the criteria for this team, you try this one, you don't quite meet the criteria for that team, and so on. But getting all of that to one place. The fourth, to delivering sort of care closer to home, so the integrated neighbourhood teams does also help with that, but the whole bits around sort of frailties or community first and so on sort of fit under that. Fifth, sort of children and young people, so many of those themes which I've just touched upon around the inequalities and the access and the care closer to home, but now sort of integrated around our children and sort of young people. As an example here, we did do a little bit of work in sort of Westminster, just trying to count the number of statutory services, whether NHS or local authority, or voluntary services in serving children and young people. We found 70, and there is a bit there on sort of how do we sort of effectively integrate them around sort of that particular sort of cohort. And so we found 70 services and a grand total of 0 people who actually knew what all the 70 services were. So it sort of speaks to the complication which is inherent in the system and the opportunity to simplify it. And then lastly, to the productive and high quality, all of the previous 5 actually cost some money, certainly on sort of the NHS side. So we estimate we're currently there's currently about £150 million opportunity just in the productivity in our sort of acute sector. Not all of that's entirely within the acute sector's control, because there are some sort of limitations on what they can do, but we have to continue to push on that to be able to liberate the funds to be able to support the other areas. So that's a sort of whistle stop through the 6 sort of significant areas. What you also have in your pack and under Annex A is the longer list of things we want to do, organised against our sort of ICS programmes, and indeed a link to the even longer document on our website which talks about that in sort of more detail. So we are now at the stage of coming out and engaging on that sort of health and care strategy. We went live on our sort of website at the end of May. We've had slightly north of 400 contributions from the public across North West London on that in the first sort of 2 or 3 weeks. That will be live until the end of July. The reason I'm here today is to sort of receive feedback from this Health and Wellbeing Board on the contents of the strategy, so what you would expect to see there and isn't there, what is there which you would not expect to see there, so where you might change or sort of modify sort of the emphasis. I will then be able to sort of take that feedback from you and indeed from all of our health and wellbeing boards and indeed our public, and then collate that and then sort of bring back to our sort of integrated care partnership, which is the body that ultimately signs this off, and say sort of yes, this strategy has support, or sort of no, we need to modify this area, change that, and so on. Thank you.
Thank you, Toby, on that. Just before we take questions and comments, if I can just bookend this conversation, just reminding, thank you for that presentation, Tony. It is around engagement. At this stage, the board has not been asked to approve anything. It's the feedback. And Jane, what I'm going to suggest is that the Health and Wellbeing Board does formally respond to the engagement anyway. Perhaps you and I can author that on taking the feedback from the group. I think it's quite important we do respond and play our role in that. So with those caveats, engagement, comments, Toby hasn't come all this way just to silence, so over to you. Any comments and observations that people would like to make? So I've had 2 or 3 occasions now to feed back on this, but people around the room. Tony.
Thanks, Keith. And thanks, Toby. Sorry, we've not met, so you will discover quite quickly I'm grumpy about everything. So don't take it personally, because it's not personal. I think for me it's a little bit kind of, grass is green and sky is blue to some degree, because there's a range of things in there that are just kind of tourisms we're all aware of, and I think in terms of at a strategy level, sort of fine, but I think the key point and the thing that needs to be sort of more visible is the notion of place being a borough, and therefore the notion of the system being the determinant as to how the outcomes that are neatly sort of captured in that 1, 2, 3, 4, 5 hexagon on page 11, whichever number, 93 that you referenced, how we address them through the knowledge of the neighbourhoods that we have in the borough and the system that we have in order to deliver against or to achieve the best outcomes for those neighbourhoods. Because otherwise, and I think it's important for people living in Hillingdon in this case, and I'm sure the same for Hounslow and everywhere else, is that the helicopter view of this gives you one view of northwest London. Our understanding of Hillingdon will help us sort of know how we'll get the best value out of the services that we're providing, because we know who the biggest users of certain parts of our system are, and therefore how we'll kind of address them. And I think just to point around, just to loop back to something Ian said earlier, I think alongside it, I think there is something about, I know it's sort of mentioned in a sort of couple of words, maybe not this, because I've seen other iterations of a much bigger document, and I think we keep talking about it certainly here, but referencing the primary care point, it's as much about how we're kind of educating how sort of wise consumers of the services residents can be, rather more than you just need more GP appointments. It's actually how do we actually sort of construct people as smart consumers to understand that no, that's not what a GP appointment is. Isn't for everything from I think I've been stung by a wasp through to my legs falling off. There's a whole range of things that can be done, and there's a lot of that information that's available by different means. So we come back to the thing that we've talked about a number of times here, sort of being around health literacy, and also about sort of communication channels and how we're engaging again with those people that we know are the heavy users of services because of their different understanding of how systems work. And they may have come from a place where there's no such thing as primary care. Well, so they're going to look for somewhere that's a big building with a big cross on it that looks like a hospital, and they're going to use it. So again, I think because otherwise we will just go through another iteration of putting out a whole load of gump about what we can do, which is really important when you look at some of the detail in it in terms of some of the conditions we're talking about. But we really need to start sort of getting into how we're going to address some of those things, and that can only be done at a more local level because we understand the dynamics of the neighbourhoods and how people are using our systems. Okay, thanks.
Any other questions or comments? Richard.
Thank you, Chair, and thank you, Toby. And we've talked about the strategy in the past, and I'm sure this board will want to recognise the roots of the strategy in a lot of the work that Place has done, as Tony has mentioned, through the joint and health and wellbeing strategy of the borough and the joint strategic needs assessment of the local populations. And I suppose for me it would be very useful to see in the Northwest London integrated health and care strategy across the 2.4 million, maybe some indications of how will we know when we have got there. what are the milestones for the metrics that we're shooting for, what are the enablers, whether that's money, whether that's workforce, whether that's estates, whether that's digital investment, to help us get there. And I think members will recognise on the report that Gary was bringing in the previous item, how much Hillingdon is achieving because the separate elements of place are working well together. We have achieved such good hospital discharge rates because community services, the local authority, primary care, the borough team, the hospital are all working together so successfully for an individual patient, but also for cohorts of patients. And it'll be useful, I guess, for the ICB to signal everybody needs to do better, and Hillingdon needs to be not only the best in London, but the best in England, or that you say, well, let's have a graded set of milestones for the whole of North West London. And I think for every strategy, we need to see what the action plan is to deliver that strategy and what the financial strategy behind that, given the enormous pressures that we know every partner in the patch are facing. But thank you.
Do you want to say anything to that, Toby?
So I'll say sort of two things. So I think I shall await your sort of formal response. But so what I'm taking from this session, at least, is probably sort of two things. So there's a bit more on sort of some of the what, particularly around the health literacy, sort of resident empowerment, sort of savvy sort of consumers, or however, whichever phrase we wish to use. But ultimately, one of our sort of mechanisms for sort of managing a sort of potentially unlimited demand for services is the sort of resilience of our residents, and so how does the strategy support that? So that's the sort of the major point I'm taking on the what. I think the other big point which is coming across is sort of greater clarity on the how, sort of particularly the sort of the who does what, and sort of getting that. So what's the role of the sort of the North West London wide bit, and what is the sort of the role of the sort of the borough bit, and in particular, sort of, at least one of the things I want to get on to is how does the North West London wide bit sort of better support sort of the borough bit, because I don't think this works with the sort of the North West London wide bit thinking it can somehow do everything or sort of take on responsibility for everything.
I'm going to, sorry, Toby, because you just continue. I'm going to go to Ian and Tony, but I guess just one thing to the caveat. I think there's a mindset shift for us, because I had this conversation with Rob this morning. It's not just about how the ICS supports place. It's how place supports the ICS, and we drive transformation from the bottom. Otherwise, you're going to have an ever increasing. Otherwise, we'll reinvent the Soviet Union if we don't watch out. So it's just understanding that interplay. I think is quite important. And I know you know that, and I know it's in your paper. But it's articulating that and moving beyond. We need to understand what place is doing, what ICS is doing, is articulating that and saying, and this is what it is. Sorry for abusing my role as chair. Ian, you next, and then let's go to Sam.
So, Toby, I'm going to go down on a different route, and I'm going to just comment on the data and digital aspect of it. And I appreciate these are the headlines, but there are a couple of just points that may just need to be just redrafted a bit. So the third point about developing a single data set of timely, detailed health care information, which we've got already. The key is getting people to use it, and that's what we've got to do there. The other point, that it's sort of, and I'm sure it's just the wording of it, you've got implementing shared records, so all clinicians supporting the health and care, no, that's the wrong one, standardising clinical systems across hospitals and care settings to allow all our hospital systems. Why just all our hospital systems? Is that a sort of just a slip, a Freudian slip in that? Or do you want actually all care settings, as many care settings as possible, to talk to each other? And finally, and this is a particular clinician's point, the last one is reducing the need for patients to repeat information at each appointment. That's useful at the reception area, But for clinicians to get a full picture of what's going on, they need to hear from the patient every single time the history of, because it's their story, and you can't get away from it. And there's this sort of dogma that once it's written down in the database on the clinical record, it doesn't need to be repeated. It does need to be repeated. Otherwise, things get missed and mistakes happen. That's got to go. It really has to change. You need to understand that for clinicians to get a full picture of what's going on with the patient, they need to get it from the patient's mouth, not from the clinical record, every single time. Otherwise, mistakes happen. Sorry about that.
So, Ian, could you...
Yeah, sorry.
I'm assuming you're going to come back on that, Toby.
I'll briefly say, and so Ian will know, particularly on the third point, that so one of the issues residents do bring up is the sort of repeated feeling they need to repeat their story more times than necessary, which is the sort of point that's sort of trying to sort of elucidate. But so I take on board the professional speaking to them needs to have the full picture, and it is unlikely that the written record is going to sort of do all of that. But there is a balance in there somewhere. On the second, okay, so there'll be a little bit in the wording, but it's as much as the the Cerner to implementation is sort of currently moving, so we're relatively confident on that. We're not about to move half of North West London from EMIS to System 1 or System 1 to EMIS. So the sort of the one system is slightly less obvious across North West London on primary care. But the point of being able to get that out into something else which can then be available back so is in the sort of longer is in the sort of broader strategy. Does that help?
I think the public they don't care whether it's EMIS. The public don't care whether it's EMIS System 1 or whatever. They just want to know that we're working towards a process. I think that wording just grates a bit because they wonder why it's just the hospitals that are doing this. It's purely wording and semantics, I think, rather than the aim behind it for the public.
Thank you. Right, I'm going to go to Sandra now.
Thanks, Keith, and much of it has already been said, but just from a social care perspective, and Toby, we have already engaged and we are talking about the strategy, but from a place perspective and from a social care perspective, I would like to feel that we're part of it and that we recognise our place within the priorities and in the strategy, and understand that whilst we've got the points here, they're example priorities, they're very good priorities, but they're blanket priorities, and we do really need to drill down in the detail to understand that they suit the local place as opposed to being a blanket across, because place does have its priorities for its population.
Tony.
Thanks. You need to pull that nearer. So practical to the end. So yeah, just but back to the same point. I think I'd also be keen that we kind of avoid getting into that the answer for North West London is 7. And because I think, again, what we may find is that locally, whilst, at a North West London level, dealing with this particular thing, the answer is 7, but actually, for us, we might want to only get to 6 in this year on that. But if we kind of put things as kind of definitive across North West London, it can look like a place has failed if it hasn't achieved that number, whereas actually within the context of its own system and what the demands and needs are locally, it may be actually totally satisfactory that the answer is 5, because actually we've overachieved on this point here, which is of a greater need sort of in the borough. So again, I think it just comes back to that, and to recognising Keith's point, which I think is right, of it's about kind of what we're doing as well, but it's but the might of things that is being put out and the engine room capacity that there is at North West London to get things out. I don't want it to become a capacity competition who's articulating sort of what the point is. So again, I think the more where there can be a discussion about how some of those caveats are included in what's presented, so that it doesn't end up being a single league table for North West London and Hillingdon is fifth because it only scored 5. So yeah, and it comes back to nuance of place, I think, against North West London.
Thank you, Tony. Jane?
Just an observation, really. I think everything's been said that I would have said, but I think Professor Goodman's made a really interesting point there about telling your story more than once. I hadn't actually thought of that until you raised it. That's why in this particular case, in a medical case, it is important. And I suppose for me, this is a document also for our residents. Whilst it's, what we do for people, the idea is they have to take it on board and they have to believe it. So for me, communication is a very, very big thing. So I'm going to be left with that comment and wonder how, when we've got documents like this, that we actually encourage and assist our residents to understand exactly why. Because the next time somebody moans to me about a doctor's asked me 15 times about the same thing, I've now got information in front of me that I can justify why that is. So I don't really know what I'm saying, but what I am saying is that when we're putting a document out like this, we need to engage the people that it's for. And there needs to be some very good pulling in the community and showing them exactly not only how we're going to do it, but why we're asking these questions. So I would just ask us as a board to just have a think about that. But thank you, Dr. Goodman, because I've learnt something today.
Don't encourage him, Jane. Yeah. I'm going to give the final on this one to our colleagues at Health Watch. Lynn.
Thank you. It does feel a little bit to me like everything, everywhere, all at once. It's massive. I mean, there's so much here. And what I'd like to see really is some sort of almost a prioritisation of the priorities, because I think to actually think that we're going to achieve all of this, and I'm not sure what the time frame is either, is slightly overwhelming.
Okay, I'll let Toby have a final say here in a moment. Any other questions, observations from people around it? Don't let me down, Tony Zeman.
Actually, Councillor Palmer reminded me I was also going to reference Ian's point because it is interesting from a practitioner point of view. If you speak to social workers or mental health workers, and they're dealing with child protection or an acute mental health issue, actually, someone just say, no, that happened whatever ago. That's not irrelevant. That is very relevant and very important. So it's a really good point. But the reason I mention it is that it does come back to that communication point, the same as the one about why we just need more GP appointments. No, people need to understand what it is and why and how the system works. Because if I've heard once, I've heard it 100 times on Radio 4 or 5 and on every blinking news programme about, people will only tell their story once. And it's as if, so then anything that isn't that is seen as a failing. That's a really good point. I hadn't thought about it either until you've raised it, but it is a really important point. And again, I think even as accepting we're not going to solve all the NHS's sort of communication issues here, but actually we can start making a difference in North West London, thinking about how we sort of change that narrative rather than we just, the same as, bed blockers. If I hear that commentary on the news again, I'll have to sort of jump off a building and become one of them in a bed or something. But it's that point of because we all know these things, but we need to find a way of addressing them in order that we can sort of, challenge some of those urban myths about things, because we spend a lot of time rebuffing or dealing with those sorts of comments or press inquiries or whatever else. So that's a really, really good point that I hadn't thought of in the same way, but we'll do from here on. Everyone will be sorry to hear. Thanks.
Okay, thank you, Tony. And just to put the final spin on, Toby will regret. Must stop calling you Tony, Toby. This whole thing becoming the story of the patient's story. I think it's about choice here as well, isn't there? There is a thing about if, as a patient, if I want to tell my story, I'll tell my story. I shouldn't have to tell my story, not personalised as you, Ian, because you haven't read my record. So I think it's understanding there's a choice element in terms of that narrative. On that point, Toby, would you just like to anything else to summarise it as?
Yes, so I'm not going to try and summarise all the different points, but I have got them down, and I await the formal feedback. And the point we were just sort of illustrating is the importance of explaining why. So entirely appropriate to tell your story in some cases, but and I wouldn't put it beyond some of my colleagues to be asking people to tell their story purely because they haven't read the record. So there's a bit of a shortcut to actually reading that they were in last week or whatever else. So and there is a balance there. So I'm just going to talk on a little bit, sort of reiterate all the next steps. So you will send me your sort of formal feedback. I'm obviously receiving feedback from all of the sort of health and wellbeing boards sort of across North West London. So I will sort of collate that and then sort of work with a sort of group of officers, of which Sandra has sort of gallantly sort of volunteered to sort of be one on there, sort of looking at the feedback as it comes in from all of the sort of boroughs across sort of North West London, and then sort of incorporate that into the strategy. Your second sort of major point on the sort of how we do this. So following on from this, then comes a sort of 5-year plan, which again we are statutorily required to do. So it is that 5-year plan where we will be sort of laying out sort of the actions sort of year by year, and hence of these sort of various different priorities, sort of which ones are sort of in the faster lane, shall we say, and which ones are in the sort of be sort of taken up sort of a bit later.
Thank you, Toby, for that. Thank you. Okay, so what I'm going to do now is recommendation, obviously, that the Health and Wellbeing Board challenges and comments on the health and care strategy, which I believe we have done. And then the other recommendation is that we do respond formally to the joint chairs of the Health and Wellbeing Board. Is that acceptable to colleagues around the table? I'm seeing nods, so I'll take that as a yes. Toby, thank you ever so much. You're very welcome to stay, but equally, if you've got other things to do, you're free to go.
Thank you.
Okay, I'm now going to move us on to agenda item 8. Sunny and Sheikha, welcome to the meeting. Good to see you. You're going to take us through the Hillingdon Tobacco Control Implementing Smokefree 2030. So, Sunny, you want to lead off for us? Good.
Thank you, Chair, and good afternoon, colleagues. So, I'm here to represent a piece of work which I think will provide great health benefits and overall impact to our residents within Hillingdon. There is a report within your packs which provides an update on the renewed commitment from the government on tobacco control. The actual Hillingdon Tobacco Control Strategic Plan, it's quite a few pages in that plan, but I hope it has a lot of information. Tobacco control is quite a big field, but it does talk about each aspect of tobacco control in detail and the action points relative to each of those points. Section 1 of the actual plan is the Smokefree Strategy and Delivery Plan. Section 2, the Tobacco Control Strategy itself. And Section 3, setting up the Hillingdon Tobacco Control Alliance, which is quite exciting, and I'll explain that in a moment. What we are going to do is a call for action in Hillingdon to refocus and prioritise stop smoking to reduce the long-term morbidity and smoking-related mortality inequalities, and to agree the Hillingdon Tobacco Control Strategy and Plan. So just a little bit of background is that tobacco smoking remains the leading cause of preventable illness and premature death in England, Almost 7 million people still smoke in England, and smoking is one of the largest drivers of health disparities and disproportionately impacts our most disadvantaged families and communities. Tobacco control itself is an internationally recognized evidence-based intervention to tackle the harm caused by tobacco. So comprehensive tobacco is more than just providing a local stop smoking service or enforcing smoke-free legislation. It's about reducing the burden of disease, disability, and death related to tobacco use. On that note, in May 2021, Professor Sir Chris Whitty, England's Chief Medical Officer, noted by the end of last year, at least as many and probably more people will have died of a smoking-related disease than of COVID-19. For most people that smoke, no other aspect of their life will impact their health as significantly, and smoking prematurely kills half of all long-term users, on average cutting 10 years from a person's life. Quality of life is also affected. For every person killed by smoking, another 30 are living with a serious smoking-related illness. The sale and use of tobacco has been highlighted by the World Health Organization as contributing to the spread of the tobacco epidemic. The illegal tobacco trade is linked to organized crime, drug dealing, money laundering, and people trafficking. Action on Smoking and Health produced a data tool which could be made bespoke to each local authority. When looking at Hillingdon, it states that the adult smokers in Hillingdon generate a cost pressure of £107.1 million annually on the economy. That equates to a cost pressure of £7.6 million on health services, productivity £94 million, social care £3.9 million, and house fires £1.6 million. Following the Javid Khan review, which listed 4 critical interventions, the recent ministerial speech focused on achieving a smoke-free 2030, a target that fewer than 5% of the population will smoke by that date, and cutting smoking and stopping young people vaping. Presently, we have a prevalence rate of 11.1 adult smokers in Hillingdon, which equates to about 25,250 people smoking. The ministerial speech suggested investing £3 million over 2 years in a comprehensive enforcement package to tackle illicit tobacco and underage below 18 years of age vape sales, including a commitment to close a loophole that allows retailers to give free samples of vapes to children, reviewing rules around the sale of nicotine-free vapes to under 18s and fines for shops selling illicit vapes, increasing education and dedicated school police liaison officers to keep illegal vapes out of schools. At present, there are no medicinally licensed e-cigarette products available on the UK market regulated through the MHRA. There's none. The long-term risks of vaping are not yet understood. Consequently, while the use of e-cigarettes is agreed by public health experts as an effective harm reduction intervention, very importantly, it is indicated for use only in those adult smokers already smoking. E-cigarette must not be seen as an alternative for smoking for people, especially young people who do not smoke. However, and very noteworthy, there have been growing concerns about the increasing popularity of disposable vapes, attractive colors, flavors with young people. Disposable e-cigarettes are now the most used products for vapers, and use has increased from 7% of e-cigarette product use in 2021 to 52% in 2022. This is a concern and needs close monitoring. Youth vaping is becoming an epidemic. Children doctors warn as they call for a ban on disposable vapes. The Royal College of Pediatrics and Child Health warned e-cigarettes are not a risk-free product and can be just as addictive, if not more, than traditional cigarettes. In May, data for Action on Smoking and Health showed there has been a 50% rise in the proportion of children trying to vape in Great Britain in the last year. There are some measures being thought about, including recommending plain packages for e-cigarettes to make them less attractive, less colourful, less flavourful as well. Many flavours out there. So, vaping is a very, very important strategy that we need to look at. We have developed Hillingdon's tobacco control strategy, which focuses on the harm related to tobacco, not only on the damaging effect it has on the body, but also the damaging effect it has on society, including the environment. There's been a huge increase of disposable vapes, lithium-ion batteries lying around, and that going to landfill can cause a huge, huge problem. This is also in addition, for example, with cigarette butts being thrown on the floor. It's harmful for wildlife as well. So these are the things that one has to look at. But I am pleased to inform you that just last week we had our first Tobacco Control Alliance meeting, which included representations from maternity, trading standards, licensing, school nursing, housing and pharmacy. We are hoping to build on that organisational input in the next meeting as well. The meeting was very, very welcomed, but the purpose of the meeting was to introduce a collaborative approach to working to reduce the harms of tobacco. Identified actions in the tobacco control plan. So again, within the PACS is a whole tobacco control strategy and plan, and in that, the Alliance member will focus on actions involving illicit tobacco, second-hand smoke, smoking and mental health, smoking and pregnancy, smokeless and niche products such as e-cigarettes, shisha, smokeless tobacco. So shisha is also another emerging, very comforting thing for young people to try. And again, shisha has many harmful effects. Some experts warn that a 45-minute session on shisha is an equivalent to 100 cigarettes worth of smoke. But a lot of youngsters are trying it because they are in different places which are very warm, they serve food, they serve lovely drinks, and they have shisha at the same time as well. So some of the things that we need to look at as well. But also the smoking cessation service. Hillingdon has a stop smoking service, but one of the areas that we need to look at through the Tobacco Control Alliance is ensure that we have increased referrals into the smoking cessation service so that they are appropriately seen to and also referred on to our partner organisations such as pharmacies. This will help us try to reduce the incidence and the prevalence of the 11.1% that is currently stated. Our first Alliance meeting allowed us to understand the work that our colleagues were undertaking to combat illicit trade. Our London Borough of Hillingdon Trading Standards mentioned that illicit vapes is one of the target interventions. He mentioned that there were many illegal vapes coming into Hillingdon. The Trading Standards Officer in Heathrow has reported 1.5 million non-compliant vapes arriving at the airport. A legal vape has approximately 600 puffs. A non-compliant vape can have between 2,000 and 4,000 puffs and come with varying degrees of nicotine juice of different strengths which are not regulated. As well as our colleague in housing who was shocked when reported that 1 in 3 smoke in social housing. He mentioned, however, there was a good opportunity to engage with this group, e.g. there is a turnover around 600 new tenancies each year, and this would be an opportunity to inform and signpost residents to stop smoking services. Our school nursing team also reported that secondary schools are approaching CNWL requesting help regarding vaping as it is a real issue among their students. The team has led a couple of assemblies about vaping. Over 1,000 students have been reached. One school has made it clear to their pupils that anyone caught with an illegal vape will be permanently excluded. And our local pharmaceutical committee, community pharmacists, also reported an increase in health issues related to vaping, including burning throats, chesty coughs and headaches. And this was really nice to see within the Alliance to have that type of feedback because we can build on those type of suggestions and ideas and move forward. In conclusion, that the Health and Wellbeing Board members, Hillingdon's health and care leaders, work with public health to ensure that stop smoking as a health inequalities intervention is prioritised and agree the tobacco control plan and support implementation. Thank you.
Thank you, Sonny. That was a very passionate, very powerful and well thought through presentation. At times scary, not because of the way you were presenting it, because of the data that you shared with us. So just to remind us before I open this up for questions, what we're being asked to do here today, the recommendations are on page 97 of the report. And I think the most relevant one is number 4 on the list, which is asking us to prioritise stop smoking as, in effect, as a partnership priority, which I think is what you're asking for today. So, yeah, okay. So I'm going to open the floor to any questions or comments. Tony.
Thanks for that. Wasn't that scary, don't worry, honestly. But just, I should know the answer to this, but I don't. Is it places where you can sort of go and use and try and whatever, do they have to be licensed?
Yes, Tony. So basically, in terms of e-cigarettes, is that? Yes. There are vape shops within Hillingdon that are providing e-cigarettes and vapes to the public. And one of our priorities with regards to the Hillingdon Stop Smoking Service is that because still there is evidence to emerge about the safety of e-cigarettes, we would urge patients to follow public health advice that if they want to use a vape, if they are smoking and adults, that they probably visit a vaping shop to discuss the correct vapes, because they are regulated through the tobacco products legislation to ensure that the correct amount of nicotine juice is there, the amount, for example, only 2 mils is within a vape, and so on and so forth.
But do you know if and again, you don't need to know the answer to this question, but because I can find out, but do establishments have to be licensed to do something other than just, say, I don't know, I actually don't know the answer to this either. Could I walk into Sainsbury's and pick up some vaping things off a shelf, or do you have to be licensed to sell those products? I suppose where I'm getting to is, do we as a local authority have any discretion over the granting of licences to establishments to be able to either sell or try or whatever? Yeah.
Thank you, Tony. So currently, e-cigarettes are not medicinal products, so they're not under the regulations. So, for example, if a person walks into a pharmacy or into a vaping shop, because they are not medicinally licensed but consumer products, they can be legally sold through a retailer as long as each of those products has been authorized to have the safe amount of nicotine in it, the amount of juice in it, and basically have a safety standard on it. So there are vapes available and they are legally allowed to sell e-cigarettes, but not as a medicinal form of nicotine replacement therapy.
Any other questions, observations? Okay. So if I try and summarise what we're being asked to do, what the recommendations are, I'm going to take the first 3 recommendations as read. The 4th one that we think we need to be explicit about is that we, as a board, work with public health to ensure that stop smoking as a health inequality is prioritised, and agree that a tobacco control plan and support implementation. Do we agree?
Yes.
Yeah. That's nods from everybody around the table. Ian.
Can I just raise a pedantic point about the first thing to recommend in this paper, which is stopping smoking is the single most effective modifiable health intervention. It probably isn't. Vaccination probably is. So I think we need to just check that we're not being hostage to fortune about this. And saying it is one of the most, it is one of the most effective, but may not be the single most effective.
Thank you. So, can I suggest that we amend the recommendation so that it is one of the hedonism can save lives on some occasions. So,
Marvellous.
You're on form today, Professor Goodman.
Ian was great. He used to review all of my papers for Smoking Station. He always got it right.
Don't encourage you, for goodness sake. Okay, so I think that has been, with that caveat, that amendment, that has been agreed. Thank you. Okay, I'd now like to move on to agenda item 9, Healthy Haze Whole System Approach to Obesity. And Shiga, I think, are you going to lead off on this one? And for us, welcome. The floor is yours.
Thank you. Good afternoon, colleagues. So I'm here to talk about, give you an update about Healthy Haze Whole Systems Approach project. The report in your packs has feedback from Healthy Haze workshop, which was held on the 28th of March. It also has a bit of background to Whole Systems Approach for those attending this meeting for the first time. But also, I've outlined a proposed plan in Section 5 for Health and Wellbeing Board agreement. So I would like for Health and Wellbeing Board to note that obesity remains a significant challenge for Hillingdon, with around a quarter of Hillingdon's adults and over a quarter of Hillingdon's children in Year 6 estimated as having BMI over 30 in the obese category. So that amounts to, I've done my rough calculations based on Hillingdon's population, around 55,000 adults and around 15,000 children are BMI 30 plus. So food-related ill health, including high BMI, is second only to smoking now as a contributor to poor health. So from smoking to obesity is the right transition. England's Whole Systems Approach is a recognized evidence-based way of addressing obesity at local level. It's a long-term measure, but which takes a systems-based approach. It requires sustained effort over long term, and hence in one of the appendices there is a scheme which shows over what time period you can expect to see outcomes, and it needs buy-in from you place leaders, systems leaders, which is essential to its success. And we also want you to recognize that this approach requires buy-in from the local people the most in local areas, because they are the ones who are going to tell us what is required in order to support them to adopt healthy lifestyles. You will recognize that life is very different in the center of Hayes to the center of Northwood. Different environment, different population, ethnicity, deprivation level, all those things which impact on people's behaviors and how they eat, how they shop, how they play, physical activity, so on and so forth. So we need involvement from your teams to play their part over medium to long term, from maternity to children to adulthood and in older people's services. This is because social care and NHS costs related to obesity are far too high, and we are currently spending on money on the impacts of obesity without realizing. Around 3% of GDP goes on addressing the impacts, poor health impacts of obesity. And one of the recent reports highlighted that each difference of 4 percentage points costs the local authority with higher obesity rates, 4 percentage point higher obesity rates, around 35 million. So if we reduce the obesity rates, we can save money that way. So it's a invest to save plan in that respect. So Health and Wellbeing Board members, Hillingdon's health and care leaders, you people are requested to consider investment into weight management, lifestyle services as well, because currently the burden of obesity and overweight is such that we cannot just focus on prevention. We need those treatment services at from tier 1 to tier 4 to work, and that's why NHS partners have their role to play in this. So in September 2022, Hillingdon Health and Wellbeing Board, we came here, we made a presentation, and you agreed for us to adopt the Whole Systems approach, which means taking systems approach. So we will be building a systems map. We've held the workshop as initial phase of this process. And this is a way of dealing with complexity where we work with people. It's a gradual way of working with people through the issues affecting them and changing those parts of system which will have impact on other things. So it's like a bicycle. That's how the whole systems approach is explained, that if you do something in one part, it will have an impact on the other part. And there is little point in preaching to people, eat less, move more, and constantly throwing that message at them when there are inequalities in our society. There are different environmental factors which impact on their lives. So this whole systems approach has 6 phases. I would also like to highlight the 6 phases are not cut in stone. It's quite flexible. It is responsible. It's responsive to the local area, where we take at local pace how we want to progress through these phases, and we know that we know that local people recognize what factors are affecting the weight gain in their respective communities. So we are in the process of collecting that intelligence from them. So we did that partly by organizing a very successful workshop where a number of local stakeholders were there, so from voluntary sector, from NHS, so CNWL and Health Watch were there as well as some community leaders. And I've included the feedback from the workshop in here. The kind of things which were highlighted were about food environments and the food system. There are far too many chicken shops and fast food outlets. Hayes is our chosen area of priority, and in that part particularly, it's quite easy to see that how environment does not necessarily support healthy lifestyle. So there are less opportunities to exercise. There are more opportunities to eat unhealthily, and we want to get to a place where the healthier choice becomes the easier choice. And in order for us to do that, we need to work with people, and we need to work with agencies beyond just the public health team, beyond just council's teams. So we conducted this scoping with community leaders, following which we got workshop from at Hayes, and we collected feedback from the workshop, and it is quite clear to see that in order for this approach to work, we will need support and as well as investment, because it's not just about identifying issues. It's how then we work with your teams and we invest into resolving some of those issues. And I've given the example of weight management services. So currently, against the need of 55,000 people, we have a service which meets the needs of only 200 people. So we have 200 spaces in our weight loss service. That's only a part of it, but there are bigger preventative programs. We have started working with schools already. So one of the things that we are doing is creating school super zones, where we are looking at 400-meter area around some of the schools. And we've identified Minette School, which is in Hayes. We are looking at a couple of other schools, and we've received funding from OHID to do some work with the communities around the school and to create to create healthy environment, work with parents and pupils and teachers and the local community. So there is a lot of work to be done on a lot of areas. We want the board to note the progress that we have made up to now, and we need support for future. And these are the proposed actions on under Section 5. The first one is setting up systems network. So we will need involvement from your senior officers, managers, stakeholders to take responsibility for relevant areas around food, physical activity, environment, economy, and work with us on ensuring that we improve the environment, living environment for people, and also to have collective ownership of the local vision and milestones. So we are going to work with people to develop a local vision of what change we want to see in the area. So is it important for us to see 2% decrease in child obesity rate? Is that our goal? Is our goal to have lesser fast food outlets in that area? And we can't just sit in our offices and identify those aims. We need to ensure that we have buy-in and ownership from wider stakeholders. Investment in weight management service. We are also working on a physical activity needs assessment and strategy, which will be ready as part of our next work in the next phase. And we are starting delivery on school super zones. Those are the five key areas we will be developing in the next phase leading up to December. Thank you.
Thank you, Shika, for that. I've got a few observations, but I wonder whether other members around the table have any questions or comments. Ian.
So, I mean, I support this. It's a difficult area. I mean, and I have to say it's a bit sort of ironic, but probably the healthiest fast food place in Hayes is McDonald's, by and large. Just if you want something healthy for fast food in Hayes, then that's probably the place to go. All the others are far, far worse. Yeah, I'm full of useless information today. So, with respect to the plan, I just wonder whether you could start a bit earlier with health visiting to the antenatal population and get them really when they're most receptive to this, and then bring them forward from there. Because I know you're starting at sort of year 2 or whatever, but whether you think about starting earlier may be more effective, or adding in another sort of bit to your armamentarium.
Very much so, Ian. Yes, that's a part of it. So CNWL 0 to 19's team was there, and we have been working with them over the past many years. So as part of our work in family hubs going forward, early years is where we start. We would like to start before that in maternity as well. But yes, you're absolutely right that in order to, because what we've noticed is that we have a higher proportion of obesity in year 6. However, that proportion in reception year is made up of children who are overweight plus obese. So they are already on paradigm to becoming obese. It's not that the proportion is less. They are on that pathway. So it is very important that we tackle early years. So we are working with them on things like promotion of breastfeeding, promotion of healthy infant feeding, and reducing the availability of sugary drinks, because one of the things we also want to impact on is dental health in children, which is also very poor and another significant public health issue.
Claire?
Just like to confirm and second what you're saying, that we've done a big focused piece of work within CNWL around the children's and the early years to see how we can prevent children going into reception. We had the data and yeah, looking at websites, education, getting in there much earlier. So yeah, we are there.
Jane?
Thank you. Shika. I was actually at the workshop and it was very, very interesting how the community came together. And I think it's a theme for me, communication again today, because there were lots of things going on in Hayes that people weren't aware of. And I know that groups of people got together after that workshop and work effectively started on that day. So I fully support this because, I can tell when I'm in my own ward what is happening by after school time. The streets are full of rubbish that is the kids are eating, and then late at night when the adults come out, it's the pizzas all over the place, and the parks are full of beer bottles and goodness knows what. So there is an awful lot of work to do here to persuade people that there are other foods available, i.e. McDonald's is so much healthier than I'm going to drive to Hayes later just to see for myself what Professor Goodman is alluding to. But I think, there is an awful lot of work that we need to do to convince children, especially, that because, we all see them going home. And it's a very complex thing, but we're all carrying around muffins the size of family cakes. A coffee and a muffin now is as common as anything, and never mind the cost of it, it's the size of it. So this has my full support, and I would like to see this rolled out much more around the borough. So it was a really, really good workshop. Thank you.
Thank you, Jane. Any other comments before I try and summarise what I think we are agreeing? Okay, so I think the approach, direction of travel, has got the support of the Health and Wellbeing Board. Some clarity on what the key next steps, what the key, if you like, drivers, what will make the biggest impact on what we're trying to do. Because as you rightly say, Shiga, this is a big area. And from a personal point of view, I consider investment all the time. My kids ask me, would you consider give me 25 quid? But it's just being clear what the ask is, because I think that's the bit that we, in the environment we're currently operating in, I think that's going to be quite important. But this is, just a reminder, this is one of our 3 health and wellbeing priorities. Hypertension, anxiety, depression and obesity are our 3 priorities. So we should be right behind this. It's just making sure that when it comes back, we are clear about what the investment is that is looking at and what the impact of that investment would be. Okay, so with that, with if you like, with those amendments, it's number 4 we're looking at here in terms of recommendations, is that the Health and Wellbeing Board are ready to consider investment into weight management lifestyle services and children's oral health to reduce food and obesity related inequalities. Is the board agreeable to that with the amendments I've suggested in terms of subject to clarity on the investment and the outcomes that we'll get for that? Yep, that is agreed. Thank you for that. Okay, without further ado, thank you, Shika, and thank you, Sonny, for taking us through that. It's been a really, really interesting session. I'm going to move on to the equally interesting point of the board planner. I'm sure you won't be able to go home this evening without having considered the board planner. That is set out for us on page 159, 160 and 161. Obviously, board are asked to comment on it. Is that acceptable, or the others you would wish to add to that going forward? Are you happy to accept it as a current work in progress? Any of those responses will be happy. Happy to just approve that at the moment as it stands. Yes? Okay, that's great. Thank you very, very much. Okay. Right, so I think we've now reached the end of the public part of the meeting. Thank you to those members of the public watching at home on YouTube. Will everyone in the room please remain silent until Democratic Services has confirmed that the live broadcast has ended and the loop has been switched off. Thank you.